Thank you for joining our Debbie Strain Foundation Curing Stomach Cancer webinar series. Today's webinar is titled Avoiding the Financial Toxicity of Cancer Care and is the 7th in a series of 12 monthly webinars. I am Mary Margaret Kilmeyer, and I'll be moderating today's webinar. I'm the Programs Director for Debbie Strain Foundation Curing Stomach Cancer and a licensed marriage and family therapist. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and members of a healthcare team. We would like to thank our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology, for providing funding to make these webinars possible. You will be able to ask questions during this presentation. You can type your question into the white text box that appears on your screen, and we will address questions at the conclusion of the presentation as time allows. In addition, we will be recording today's webinar, and that recording will be accessible on our website in the lecture library section. First, I will share information with you about our president and founder, Debbie Zelman, and Debbie Strain Foundation Curing Stomach Cancer. Then we will hear a presentation on avoiding the financial toxicity of cancer care from Dr. Yousuf Zafar of Duke Cancer Institute. The presentation will then be followed by the questions and answers session. Pictured here on your screen is the president and founder of Debbie Strain Foundation Curing Stomach Cancer. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. A practicing attorney and mother of 3, she had no risk factors for stomach cancer, and her symptoms were very vague. At the time, she was told that her chance of being alive in 5 years was only 4%. She has endured harsh chemo regimens and targeted treatments and experienced many recurrences over 9 years and is still a patient to this day. Debbie founded DDF in April of 2009. As an organization, we are a member of several advocacy coalitions, including the Deadliest Cancers Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie serves as a patient advocate on numerous committees and task forces. Some of you may be familiar with the facts and statistics about stomach cancer, and they are continually being updated. In 2017, it's estimated that more than 28,000 Americans will be diagnosed with stomach cancer, and more than 11,000 will die from the disease. 80% of all patients in the U.S. are diagnosed at stage 4, when the 5-year survival rate is only 5%, and the incidence rates in younger populations is increasing, while the expected frequency has been on the decline. Yet, very many know much about this deadly disease. Debbie Strain Foundation is dedicated to raising awareness about stomach cancer, advancing funding for research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more about our organization by visiting our website, www.debbiestream.org. In short years, DDF has achieved many milestones. We have 27 chapters across the U.S. as well as chapters in Canada and Germany. There are events ongoing around the country. Our patient resource education program helps patients, their families, and caregivers around the world by matching them with survivors and caregivers using disease-specific criteria, including stage, their biomarkers, and location, and much more. We host educational webinars, such as the one you will hear today. Symposia are hosted year-round, and our website contains in-depth information about stomach cancer that can be translated into more than 60 languages. We have also been able to provide $650,000 in research grants and have advocated during our Stomach Cancer Capitol Hill Advocacy Day to add stomach cancer to the Department of Defense's peer-reviewed cancer research program, resulting in nearly $12 million being awarded to stomach cancer researchers. Here is a snapshot of our website's homepage with links to the numerous resources, including our online stomach cancer support community. And here you can see many of the events we have on the horizon, including our teams participating in races and runs, such as the Chicago Half Marathon and 5K, as well as the annual Dream Big Luncheon celebrating Debbie's 50th birthday, which will be hosted on September 25th, 2017 in Weston, Florida. There are also golf tournaments in November in North Carolina and Florida. In addition, the month of November is known as Curing Stomach Cancer Month. See our website's advocacy page for more information to declare this in your state. For more information about any of these and other events, please go to our website and click on Events. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday from 8 a.m. to 5 p.m. Eastern Time. Also on this slide are important phone numbers and email addresses that you can use to contact our office and our staff. We will now begin the presentation made possible in part by our title sponsor, Boston Biomedical. The topic this month is Avoiding the Financial Toxicity of Cancer Care, and our speaker is Dr. Yousuf Zafar of Duke Cancer Institute. Dr. Zafar is a gastrointestinal medical oncologist and healthcare delivery researcher. He's an associate professor of medicine and public policy at the Duke Cancer Institute and Sanford School of Public Policy. He serves as the director of the Center for Applied Cancer Health Policy at the Duke Cancer Institute. And with over 80 publications, his research explores ways to improve care delivery for patients with cancer, with a primary focus on improving affordability of treatments. His work has been covered by Forbes, the Wall Street Journal, the LA Times, NPR, and the Washington Post. We thank him for joining us today. And now, Dr. Zafar, I will turn the webinar over to you.
Thank you very much for having me. It's really an honor to present to your organization. So I'd like to talk today about this concept of the financial toxicity of cancer care and what to do about it. And I will talk from the perspective of an oncologist who treats patients with gastrointestinal cancers who experience this problem, and from the perspective of a researcher, where I get to think about it from a slightly different perspective. Next, please. But before I start, I'd like to tell you a story about my patient. This is Chris. Chris was diagnosed with colorectal cancer at a pretty young age. And when I saw him, he had localized cancer, meaning just in one place. And so started him on a very standard regimen of radiation and chemotherapy, and he did really well with it. He received oral chemotherapy and, like I said, radiation. After completing that treatment, I repeated some scans and unfortunately found that his cancer had spread. So I brought him back in and we started talking about the fact that his cancer has spread and that I was going to propose different treatment for him, this time just chemotherapy, that also included that prior chemotherapy that he'd been on, that oral chemo. Chris did really well with that treatment. He had no side effects. And as I'm telling him about this treatment, expecting that, again, he'll do well with the subsequent treatment, he interrupted me and said, "You know what, doc? I can't do this treatment." And that really caught me off guard. But it turns out it wasn't the physical toxicity that Chris was concerned about. He was concerned about the financial toxicity. You see, Chris had a job, he had insurance, but he didn't have any coverage for his prescription medication, which means he paid for his oral chemotherapy fully out of pocket without complaining about it or letting anybody know about it even once, resulting in thousands of dollars in medical debt just over the course of about a month. Unfortunately, Chris is not alone, and many patients every day face the same situation. As they're struggling with their cancer diagnosis and their cancer treatment, they're also struggling with the financial toxicity of cancer care. And I think what happened to Chris happened for two reasons. First, Chris never mentioned this problem to anybody on his healthcare team, and he didn't mention it to me. But I think the second reason was even more important, and I'll get back to that later on. Next, please. So what I'm going to talk about now is why cancer treatment is so expensive for patients and what we can do about it. So we've seen that the overall price of cancer care has risen dramatically and will continue to rise dramatically, becoming one of the most expensive set of diseases to treat in this country. So why is that? Next, please. Well, a lot of it has to do with the price of drugs. The drugs that we're using today are really expensive, and those prices have increased a lot over the past few decades. So each one of these little dots represents about a month, the cost of about a month of chemotherapy. So in the 1970s, on average, a month of chemotherapy cost maybe a few $100s. Fast forward to today, where a month of chemotherapy costs or tens of thousands of dollars. That is a dramatic increase. So why is that? Why is chemotherapy so much more expensive? Next. Well, part of it has to do with the type of drugs that we're seeing today. So yes, the drugs that we're seeing are working better than they did in the 1970s, but they're also different mechanisms. So we're seeing more biologic agents, for example, monoclonal antibodies, targeted drugs that you may have heard of. So in 2003, these biologic agents comprised about 10% of the oncology market. Next. Fast forward a decade, and now those drugs comprise at least half the market, if not more. And this data doesn't include any of the immune therapy drugs. Next. And in fact, these drugs are really taking over the treatment of cancer. And in many cases, they've done a lot to really help our patients. But they're also being, I think, marketed in ways where there seems to be this promise, at least, of benefit to everybody. And unfortunately, that's still not the case. Yet we've seen a huge uptick in the use of these drugs. Next. So this chart looks at how the uptake of these drugs over the course of a year. So in November 2014, you can see that just a few thousand units of these PD-1 inhibitors or immune therapy drugs were sold that month. Fast forward a year, in November 2015, over 500,000 units were sold. And again, that's just over the course of the year. And these drugs are incredibly expensive. But what's interesting to me is not so much the price of a drug as it enters the market. Next. But actually what happens to the drug's prices after it enters the market. So this is data on the price of 3 drugs per pill and how those prices changed from 2007 to 2014. So, for example, the price of a dasatinib increased by 130%. And again, this is per pill. The price of erlotinib increased by 90%. And the price of imatinib, or Gleevec, which is used for chronic leukemia, increased by 158%. So not only are drugs coming in priced high, but those prices are increasing over time, which seems to defy the laws of economics. Next. So what are we getting for these drugs in terms of these high prices? And I think the prices would be fully justifiable if we were seeing, we're seeing a 100-fold increase in price over a few decades. Are we seeing a 100-fold increase in outcomes as well? And unfortunately, we're not seeing those same benefits. So this study looked at about 56 drugs used to treat cancer, looked at the price of the drugs per year, and then looked at how much those drugs improved overall survival. And what they found was that there was no relationship between how much a drug cost and how much it actually improved survival in comparison to the standard of care for any particular drug. So if you look at the large diamond, you can see, in fact, the most expensive drug in this study improved overall survival by just 20%. So drugs are improving for sure in terms of the quality of care, but their price is increasing out of proportion to the amount of benefit they're providing. So why else is treatment expensive? Next. We've talked about how the pharmaceutical industry is developing drugs and pricing them, but we also need to talk about the insurance industry and insurance design and how that's impacting patients in terms of how much they're paying for care. And what we're finding is that insurance is becoming more expensive. So let's look at the data for how much premiums have increased over time. So this is from 1999 to 2013. You see inflation as a baseline. Next. And worker earnings have kept up with inflation for the most part. Next. But we see that premiums have increased by 182% in this time frame. Next. And even worse, how much we contribute to premiums. So not how much our employers contribute, but how much we contribute to premiums has increased by nearly 200%. So insurance is expensive even before patients have to deal with that catastrophic illness. The deductibles have increased as well. And in fact, over the past few years, deductibles have, the average deductible has nearly doubled in size. Next. we're also seeing an increase in the number of what's called tiered formularies. So that means generic or less expensive drugs fall on the lower formulary, the lower tiers, and so patients pay maybe a couple of bucks a month for those generic drugs, while expensive drugs fall on tier 4 or 5, and patients pay $30, $40, or $50 a month for those prescriptions. And not surprisingly, almost all oral anti-cancer therapy and some of the expensive nausea and pain meds that our patients use fall into those higher tiers, meaning patients are paying more for their prescription drugs as well. Next. So what does that all mean? Well, it means that patients are paying thousands of dollars a year despite having insurance for their cancer treatment, whether it's IV therapy or whether it's oral therapy. And this is definitely having an impact on our patients. And this is where the financial toxicity of cancer treatment comes into play. Next. There was a study that was done a couple years ago in Washington State where they found that just having a cancer diagnosis was associated with a 2.6 times higher risk of declaring personal bankruptcy. So not the type of treatment that a patient faces or the cancer diagnosis, just any cancer diagnosis was associated with a greater risk of declaring bankruptcy. And what's worse is what that declaration of bankruptcy or this extreme financial toxicity can do to a patient. Next. And the same investigators who did that study did a follow-on study where they found that cancer patients who declared personal bankruptcy were at a 79% greater risk of dying as a result. So it's not just facing that financial devastation, but in fact, financial toxicity can actually impact patients' outcomes. Next. So why is that? What explains this link between extreme financial distress and patients not doing as well? Well, I think there are a few things that explain it. Next. And the first is well-being. So this is where I have done a good amount of research on this question of how does financial distress, financial toxicity impact patients' well-being. Next. We did a study where we found, where we did surveys of patients who were getting cancer treatment, all of whom had insurance. And we asked them, what have you done to deal with your costs of care? A majority said they'd given up vacations. Nearly half had cut back on food and clothing, and nearly half had spent their savings to help pay for their cancer care. Next. We also asked patients what would they be willing to do to help pay for cancer care, and half said they'd be willing to declare bankruptcy. 39% were willing to sell their home, and a large proportion were willing to spend less on food and clothing. So clearly, these high costs are impacting patients' lifestyles and their overall financial well-being. Next. But it's also impacting their quality of life. And health-related quality of life is really a distinct entity from financial well-being. Next. And we found in a study that we did of 1,000 patients that patients who had high financial burden reported worse quality of life. And this is not just patients who are receiving treatment, but it's cancer survivors as well, who are a year or two out from treatment. We're still feeling the effects of financial burden and still had worsened quality of life in association with that financial burden. Next. So I think one of the most important factors that can explain this relationship is quality of care. And by this, I mean being able to afford the treatment that your doctor prescribes. And there's a lot of evidence now that patients can't afford it. And because they can't afford it, they may not be taking it, that treatment, the way their doctor prescribed. Next. There was a really interesting study that looked at treatment for chronic leukemia with that drug I'd mentioned earlier, imatinib or Gleevec. This study looked at patients who were starting treatment for Gleevec and looked at how much they were paying out of pocket for that drug despite having insurance. And the study found that patients who had higher out-of-pocket costs for Gleevec were 70% more likely to stop taking it. So what was a higher out-of-pocket cost in this study? It wasn't thousands of dollars a month or even hundreds of dollars a month. It was about $50 a month. So patients who had out-of-pocket costs higher than $50 a month for this potentially life-saving, if not life-prolonging drug, were more likely to stop taking it. Next, we also found in the study that we did that about half the patients we surveyed were somehow non-adherent to their treatment because of cost, meaning because they couldn't afford it, they weren't taking their treatment. Next. So there are at least a few factors that might explain this relationship between financial toxicity and a greater risk of dying or doing worse in terms of the cancer. And there might be others that I haven't mentioned or that maybe you've thought of just as you're watching. But what we have really is a growing list of evidence-based financial toxicity. So each of the things you see on the screen here, there's been a study that has described this happening for the patients are doing in order to save money. Next, and so now is the time to intervene. Now is the time that we need to start doing something about it. So how do we do that? Next, well, I think we need to intervene at 3 levels. We need policy interventions. We need interventions at the provider or doctor, nurse practitioner level, and at the patient level. So let me go through some of these. I want to talk about some policy interventions first. My main interest is in the provider and patient interventions, as I'm sure is your interest as well, but we need to talk about the policy interventions because most of this change can't happen without that. Next. So if we're talking about policy interventions, we need to talk about what we can do with manufacturers, the government, with insurers, and with health systems. Next. So let's talk about manufacturers first. So what can manufacturers do? Next. Well, it's not rocket science. They need to lower drug prices. I think it's fairly obvious that drug prices are too high. And there has to be a way where we can lower drug prices and still innovate and bring great beneficial new drugs to market, and to be fair to the pharmaceutical industry, still let them make a profit. The CEOs of the pharmaceutical industries have started talking about this too, and have admitted that their drug prices are too high. But what we need to do is turn that talk into action. Next. And one more. So that's what we can do, that's what manufacturers can do, quite simply, is to lower drug prices. But what about the government? What can the government do? And to be honest, the government really needs to get involved at some point. Next. Well, when the government did get involved in 2003, President Bush signed the Medicare Modernization Act. And what this act did was create Medicare Part D. So as a result of Medicare Part D, thankfully our seniors were able to get access to prescription medications that was covered by Medicare now, which is fantastic. But there was 2 lines, literally 2 lines in this 16-page bill that forever changed the way that drugs were priced in this country. Next. And these are those 2 lines. And basically, hidden in the middle of this bill was really important law that said we are not allowed to negotiate prices with the pharmaceutical industry. So as a result, we're not allowed to do what happens in Australia, in Canada, in the UK, and in Europe. We're not allowed to negotiate drug prices. So this is one of the first steps that the government can take, is start negotiating prices with the pharmaceutical industry. Next. So after that creation of Medicare Part D, the next big evolution in health policy, of course, was with the Affordable Care Act. And so what has the Affordable Care Act done for affordability of treatment? Well, I think there is absolutely no doubt that millions, and to be exact, about 23 or 24 million people now have access to health insurance who didn't prior to the ACA. And the previously uninsured people and the very poor clearly have lower health costs as a result. But one thing we are seeing with the ACA that we need to keep in mind is that deductibles have increased, and so patients who have insurance might be paying as much or more for their health care. Next. And so what's in the future? Well, the American Health Care Act is probably not in the future of healthcare reform. And to be honest, if this bill were passed, there was really nothing there that would have decreased cost for our patients either. Next. So clearly there's a lot that the government can do to reduce prices, reduce costs for our patients. Next. But what about insurers? I think the insurance industry has a huge role to play in lowering costs. And one of the best examples of what the insurance company can do is focus on something called value-based insurance design. Next. So what value-based insurance design means is basically patients should not get penalized for receiving high-value, effective treatment. But maybe we should be discouraged from using low-value treatment. Next. So here's an example. So we know that there's a drug called bevacizumab that's been used in GI cancers and colorectal cancer for years now. And we know that it is not effective in pancreatic cancer. But we know, as I mentioned, that imatinib can really save lives in chronic leukemia. So if a doctor were to prescribe prescribe bevacizumab for pancreas cancer, there's no evidence for that. We know it's not helpful. Maybe there should be a sort of low-value penalty for that. Next. But if a patient were to receive imatinib for CML, they shouldn't have any out-of-pocket costs for this very high-value, high-benefit treatment. And we've already seen where costs, even in the range of $50 a month, can induce patients to stop taking this very beneficial drug. So next. So maybe insurers could start expanding these value-based insurance designs as opposed to using a sort of shotgun approach where everybody has a copay no matter what the treatment, no matter what kind of benefit you get from treatments. Next. But what about health systems? So I don't think health systems honestly get picked on enough when it comes to lowering the cost of cancer care. And there's a lot that health systems can do. Next. So when patients go to a hospital or a cancer center for cancer treatment, they rarely have any idea how much their treatment is going to cost upfront. And they really have no way of comparing the cost of treatment between Cancer Center A or Cancer Center B. So I'm a huge advocate for price transparency, where our patients really have the opportunity to see how much they're going to pay, if not to shop around because maybe they want to get treatment at a certain place, but at least to prepare, because I think preparation can really do a lot for a patient in terms of understanding how much they're going to end up paying out of pocket. Next. So that's just a very, very quick overview of some policy interventions. But let's move on to the part that I'd really like to focus on, which is patient and provider interventions. And this is where, I like to say that this is where the rubber meets the road. This is where we could make changes tomorrow in clinic, in terms of where I, as an oncologist, practice, and in terms of where those of you who are patients or caregivers might be able to make changes. So one way to think about it is to think about financial toxicity as a symptom. Next. So how do we treat symptoms? Well, let's take fatigue as an example. Fatigue is a symptom of treatment and of cancer. We want to prevent it as much as possible. We want to assess it, so we want to measure it and ask patients about the degree of fatigue they might be experiencing. And then we want to reduce it. No matter what we do to prevent or assess, patients are going to still feel some degree of fatigue through treatment. So we want to do whatever we can to reduce it. So next, let's take fatigue and switch out financial toxicity. And that's how I'd like you to think about it. Think about it as a symptom that we want to prevent, that we want to assess, and that we'd like to reduce. Next. So let's talk about what we can do to prevent financial toxicity. This is where we need to think about value in care. And we need to think about how can we provide our patients with the highest value care that is of lowest cost to them. Next. So this is where we need to focus on high value interventions, and there are organizations that are already doing that, right? And next, so Choosing Wisely is an initiative of the American Board of Internal Medicine Foundation. And the Choosing Wisely organization has developed lists of interventions for multiple different subspecialties, and cancer is one of them, where we know that these are interventions that are not helpful and we should avoid. Next. So one of the highest rated items for cancer is basically to not to treat patients with harsh chemotherapy when we know that chemotherapy will end up hurting the patient more than it will helping. And this is usually for patients who have unfortunately been through multiple treatments already and who are more likely to feel the side effects of chemotherapy rather than the benefit. Next. So what does this really mean? It means that I, as a provider, need to do a better job of having goals of care discussions. So what do? Well, I ask my patients, what's important to you? And I learn from them how their goals should really shape the treatment that I prescribe. And that's really important when it comes to costs as well. Not all patients have problems with costs or even want to talk about it, but it might be an important goal for certain patients. And having a goals of care discussion is where something like that could come out. Next. So what about assessing for financial toxicity? So again, this is an area that we do a lot of assessment for when it comes to other symptoms. So next, in clinics, clinics that you might be going to, and I know here we do at Duke as well, is we will measure patients' symptoms over time. We'll ask them about their nausea, for example, or their fatigue, and we'll see how that might wax and wane over time. So this blue arrow at the bottom of the screen is, let's say, a course of treatment, and the gray dot might be a change in treatment. So if we're measuring patients' nausea or fatigue, for example, every time they come into clinic and we track it over time, we might see how that changes as they start a new treatment. But if we don't measure financial toxicity over time, then a new treatment might induce incredibly high costs for a patient that we just never pick up. So I really advocate for measuring financial toxicity regularly as we do our other symptoms. And to be honest, it doesn't have to be complicated. It could be something very simple, like asking, so can you afford your treatment? How are you doing with paying for your care? And then going from there. Which brings up next, the last point, which is reducing financial toxicity. And this is where actually a lot more can be done than you'd expect. I think most people are very surprised to hear that we can do a lot to reduce financial toxicity, even for patients who are experiencing it. Next, but the first part has to come with a conversation. We need to know about it before we can do something to reduce it. So, we did a study where we asked patients whether they wanted to talk to their oncologist about cost, and about half said they wanted to have a cost discussion, but only 19% actually had that discussion. So there's this huge divide between patients who want to talk about cost versus those who do. So we asked those who had not talked about cost. We asked them, so why haven't you had a cost discussion? What's preventing you from talking about cost? And the answers were interesting. So the majority said, well, I don't think it's a big enough problem to bring it up. Over a quarter said that they were afraid of receiving lesser quality care if they talked about cost. And actually, and I'll show you in a minute why that's not not actually the case most of the time. Some patients were embarrassed to talk about it, and some said, well, it's not really my doctor's job. And I'll get back to that one in a minute too. So what about this small group, this 19% who said they had a cost discussion? So we focused on them too, and we asked them, well, look, when you talked about cost with your doctor, did your cost go down? And 57% of patients who had a cost discussion said their out-of-pocket costs were decreased as a result. And that to me is really interesting. Next. So how were those costs decreased? Well, if you look at the lower two bars, in 78% of the time, those costs were decreased without changing any treatment. But just by the healthcare team knowing that patients were having a problem with costs, they could talk to the insurance company, or they could refer the patients to a financial assistance program or to a foundation to help reduce their costs. So I really can't emphasize enough that having that cost discussion is the first step in reducing financial toxicity. And it's not that your doctor needs to know the answer, but I'm pretty sure that your doctor will know who to point you to in terms of financial counselors or social workers or pharmacists who can help you find the resources that you need. So what are we doing along these lines? Next. Well, a lot of my research now is focusing on developing tools for patients to use, so patient-level interventions. That helps patients through the process because, I think it's very easy for me to say, sure, you should talk about your costs, but it's challenging. It's really hard to do. And so we're developing a tool called Pathlight, which is a financial assistance, navigation, communication, and education tool. So this tool has 4 parts, or will have 4 parts when it's ready to go. So the first is that it will screen for financial toxicity. So as patients answer questions as a part of this online tool or app, they might answer questions in a way that suggests that they're going to start having problems with cost. And if they're sort of flagged as in need of some assistance, then we'll contact their financial counselors to let them know that this is a patient that you need to talk to. Second, it provides a knowledge center where we've collected resources from all over that we have curated, where patients can search this large database for topics that are important to them. So maybe they want to know how the Affordable Care Act will impact their access to clinical trials, or maybe they want to learn what a deductible is. You'd be surprised, 40% of Americans don't know what a deductible is. And so we provide that education in a way that patients don't have to read through a 200-page document, but can search very quickly for terms, or even just browse through and look for topics that might be interesting. And then we also, as a part of that, connect patients to a community of other resources, so contact numbers, websites, of other resources and foundations to go to for help. Third, as a part of this tool, we can help teach patients, coach patients who want to talk about cost through that process of having a discussion. And it's really interesting, but learning how to bring up a really sensitive topic is actually a learned skill. And so we take patients through a 4-step process where we say, like, first, identify your costs, and we have a built-in cost diary that patients can use. Second, learn how to talk about your costs and actually mention it. We have a little interesting tool that can measure how concisely you can bring that up. And then third, ask the question. So ask for help, and a lot of patients don't actually realize that there are ways that you can ask, and there are questions you can ask. And we have a question bank of many questions that we've put together that other people with cancer who've faced cost issues wish that they should have asked or did ask. And so we have that question bank available to ask a question. And then finally, having patients sort of make a plan in terms of how and when to have that cost discussion, and with whom. Maybe it's not your doctor. Maybe it's a social worker, a financial counselor, or a nurse, and that's totally fine. And then the last part of the app that is really exciting to me is that we can collect patients' insurance information, their cancer diagnosis, their household income, and their the treatment that they're on, and based on that information, suggest financial assistance programs for which that they particularly might be eligible, and then provide them links to help start that application process to get assistance specifically for the drugs and treatments that they're on. So this tool is in development right now. We actually have some funding from the National Cancer Institute to develop some of it. And my hope is that we'll have prototypes out by early next year. We're working with a couple other foundations, including the Cancer Support Community, to help develop some of the content and to help disseminate it as well. Next. So this brings me back to Chris. So if you remember, Chris had incurred thousands of dollars in medical debt because of the treatment that I had prescribed for him. And it said, there's two things that really caused Chris or that contributed to Chris accumulating this medical debt. So the first, as I mentioned, was that Chris never mentioned to anybody that this was a problem. We could have done something to completely avoid the debt if anybody on his healthcare team had sort of known at the time. But the second part is way more important. And the second part is that I, as his oncologist, should have asked him, right? And I didn't. But that's the part that I've learned from. And this was where a lot of my research is coming from as well, is this idea that we need to engage, both patients and providers need to engage on this topic, not fear lesser quality of care or fear embarrassment or anything. But I think the key is that if we know as providers what patients are going through, if we're all on the same page, then we can help you find a solution. So I will stop there, and I'm happy to take questions.
Thank you so much, Dr. Zafar, for this information about an important topic that clearly impacts everyone, not just cancer patients, and not any one type of cancer patient. So I know it's a very sensitive but very important topic, and we really do appreciate your expertise in sharing your knowledge with us today. So we'll go ahead and read some of the questions that came in during your presentation. The first being, and I'm going to just kind of try to go in order here of receipt, is do you see or have any research that the increasing costs of care are relative or proportionate to the declining health or of an aging population?
Not necessarily. I think what we know is that, so I guess is the question asking just, in general in terms of the U.S. population?
I believe
so. Yeah. No, not necessarily. I mean, I think, yes, it's potentially those two things are happening at the same time, but I'm not sure they're necessarily related. Like I said, there's many reasons why the cost of care is increasing. But part of that is that we're using a lot more healthcare as well, and that's where you might start seeing sort of a little bit in terms of the, a declining health of the population. But I'm not sure those are both completely related.
Okay, thank you. And going back to the policy level interventions, what would you suggest could be the patient's role or ability to affect change at that level in terms of either advocacy or, perhaps getting involved in government or, creating some of this change?
That's a fantastic question. So I agree. I mean, I don't think, I'd shown those three circles of policy, provider, and patient. I don't think we're stuck in any one circle. We've got to cross into the other realms. And I would say very simply, call your representatives. I think what they need to hear is what patients are going through. And the more they hear it, the more they realize it's a problem. So I am a part of a few sort of government relations committees through national organizations. And a part of that, I went to go speak to the staff of one of my U.S. senators. And as I was talking to them about this problem, I realized that they didn't even really understand the extent of it. And it's something that I had taken for granted, and I assumed that they understood in terms of the financial toxicity that patients are experiencing, but they didn't. So, simple emails, simple calls to bring visibility to the problem can impact change over time.
Thank you so much for that. And just as a follow-up, I know as an organization, Debbie Stream Foundation, we work to impact the policy level in terms of research taking place for stomach cancer. And that can be very much about timing. Do you have any suggestions or recommendations around timing? Is there a particular vote or legislation that patients should be aware of to get their voice heard?
So that, I think, depends a lot on what's happening locally. So it depends on, what's happening in the state governments as well, which can be really important and sometimes overlooked. In terms of the federal government, sometimes that can make a difference. And there's, a couple of bills that are going through the House of Representatives right now that might be worth thinking about. So one is looking at introducing cost parity between oral and IV chemotherapy, and then the other is looking at access to cancer care as well. Considering the cost issue. So yeah, sure, timing can be important, but really, it doesn't even take that much effort. I mean, I think just sort of talking to your representatives about your particular experiences is powerful enough.
Great, thank you. And just as you mentioned that, it actually relates to another question we received regarding biosimilars. And how do you see that as an impact on the cost of care of this new creation of biosimilars and their acceptability or approvals?
Yeah, it's really interesting. I mean, if you look at biosimilars and generics, and so for those of you who don't know, biosimilar is basically a drug, a biologic agent, biologic drug or a targeted therapy that is similar in mechanism to an on-brand drug. So it's kind of like generics for biologic agents. Really, there's not a ton of evidence out there right now in terms of the impact of biosimilars on cost, aside from the fact that their prices are about the same. So they haven't really reduced costs a ton yet. And we're not completely sure why, but I think a lot of it has to do with production and that it's still costing a lot to produce those drugs. And so they haven't been able to reduce costs very much.
Okay, thank you. And the last question that we'll have time for today is regarding the Choosing Wisely database that you had mentioned. Was this a publicly accessible database that patients can access?
Oh, sure. I mean, it's basically just lists that have been created by Choosing Wisely, and you can just go to their website at choosingwisely.org, and you can see those lists.
Okay, all right, wonderful. So I think that sounds like a very a really interesting new way, at least that I wasn't familiar with, that patients can become more versed in the financial aspects and efficacy of their treatments and become better consumers of healthcare as well as advocates for themselves.
Absolutely.
Wonderful. All right. Well, thank you again, Dr. Zafar, for your presentation today, as well as sharing all of this information. We really do appreciate your time and expertise.
Oh, it's my pleasure. Thank you so much for having me.
For all of our listeners, as you know, this webinar was brought to you by Debbie Stream Foundation Curing Stomach Cancer. The recorded version of this and past webinars can be found in the lecture library of our website. I would like to thank again our sponsors who helped make this webinar possible, our title sponsor, Boston Biomedical, as well as our platinum sponsor, Lilly Oncology. As a reminder, please check our website and the events listing, as well as your calendars, to join us for an event near you, or let us know if you'd like to get involved in fundraising or awareness event, particularly for the month of curing stomach cancer in November. Thank you so much to all of our listeners today. This will conclude the 7th in a series of 12 webinars. Our next webinar will be hosted on September 29th at 12 noon Eastern Time. And again, to review recorded webinars, please visit our lecture library. If you have any questions, comments, or feedback, we would love to hear your thoughts before September 29th. So please send those to patient.resource@debiestream.org. Thank you for joining us.